if you are kind of a one-trick pony and you're like, oh, I just take care of shoulders, and you don't think about the nerves coming out of the neck, you'll treat someone and it won't help them.
You're listening to the Ethos Athletes Podcast, where we believe that your health is the number one resource you need to accomplish your dreams. My name is Dr. Matthew Hernandez, and I'm a physician dedicated to helping my patients maintain their active lifestyle and continue doing what they love. I'm sitting down with other experts so that we can provide our listeners with the knowledge they need to improve their health and live their best life. Hey everyone, this is Dr. Matthew Hernandez, and you're listening to the Ethos Athletes Podcast. Today we're going to be discussing regenerative medicine for shoulder pain. And for this particular podcast, just like in the rest of this series, I have Dr. Kellum, who is an orthopedic surgeon, a regenerative medicine specialist, owner of Nashville Regenerative Orthopedics, and former team assistant to the Boston Celtics on this show to discuss everything with us. So Dr. Kellum, welcome back to the show.
Hey, thank you very much, Matthew. I really appreciate it.
So in our previous episodes, we've discussed how both myself and Ethan go and actually approach joint pain. And part of this approach is using what's called the SANS method. And this particular method is a comprehensive approach that we use in order to really figure out the different components of what's causing a patient's joint pain. Ethan, why don't you go ahead and walk us through the basics of that approach again?
Yeah, so SANS is the acronym that stands for, number one, symmetry, next, articulation, then the N is for neuromuscular, and then the last one is for stability. And so all those things really go into helping, one, alleviate joint pain, or two, understanding why we have joint pain, why we've gotten there. And so we like to look at those things as we evaluate a problem, someone that comes in, they're having joint pain. You really need to take each of those things and say, okay, is this off? Is this off? Is it? And then try to put that whole story together to try to help someone with that. If you address one, you don't address the others, you don't get very far down the road. And so it's very important to kind of have a, as you take those group of things and really apply that to the shoulder as well as other joints too.
Yeah, absolutely. And so part of this SANS approach, like Ethan had mentioned, was a lot of times when people have joint pain, they might go to a practitioner, and a lot of practitioners only really look at maybe one, maybe two components. And so there's times when people will go in, get treatments done, and then the treatment didn't work. And usually It didn't work because one of the there's four pieces to it, and one of the others, so a piece got missed in there that wasn't either evaluated properly or the proper therapy wasn't indicated. And so if you want to go learn a little bit more about that in detail, you can go check out our previous podcast on that approach to joint pain. And you can learn more about how, again, myself and Ethan approach this. Now, today, like I said, I want to discuss more regenerative medicine for shoulder pain. And what I'm hoping you'll get from this episode is really learning basically that there's more than one way to go and see what's going on with the shoulder as far as imaging goes. A lot of people are used to hearing you need to get an MRI. I think today we're going to discuss another therapy that's another image, another type of imaging that's not as commonly known, but that works extremely well for diagnosing shoulder pain. And then we're also going to discuss what types of therapies what regenerative medicine therapies can actually treat the shoulder.
Right.
Ethan, let's discuss imaging. So let's say you had a patient come into your office that has shoulder pain. You use the SANS approach for them. You have an idea what's going on. How do you determine what kind of imaging to use to figure out or to see exactly what kind of tissue damage is there, if there is any?
Yeah. So, the number one, the very first one that is kind of like, number one is going to be getting an X-ray. So, looking at the bony components, you don't see soft tissue very well on that, but it gives you a good sense of what's going on, potentially articular within the joint. So whether there's arthritis that's there, or in the glenohumeral joint, or the AC joint, or whether the bones are positioned in the right place. So that's the first one that we start off with, and always want to look. And sometimes people are like, well, why do we have to do that if we're going to get some other imaging? But it gives us a really good sense of just kind of like, kind of a 30,000 foot view of what the shoulder looks like. And so certain views on x-ray can definitely clue us into certain disease pathologies in the joint. So that one is very, very important. And once again, a very good clinician can take an x-ray and certain views and get a lot of information about the shoulder from that. So that's the first one that we do.
Yeah, absolutely.
The next one, and I'm going to talk about. We'll talk about the second one or the third one here in a second. But the second one that I really like is what we will mostly get is an MRI, and so people will know about that. And MRI is really good because it gives us once again a great sense of the soft tissue, whereas X-ray gave us a good sense of the bone. MRI gives us a great sense of the soft tissue. So we're looking at that biceps tendon, that rotator cuff. We see more of that AC joint and what it looks like in there. We can see bursitis or fluid within the joint now, and evaluate the subscapularis, which is that tendon in the front. So it gives us a really good opportunity to look a little closer. And I say that's you're starting to get down to that 5,000 foot view with that MRI. So now you're honing in and you're seeing all of these structures extremely well, and it gives you some nuances that you maybe not pick up on exam or once again can't pick up on x-ray to what's going on with someone. And then you move from there, and the one that people don't use a lot, and I use this mostly in the office, and it's going to be ultrasound. So ultrasound is good for one, diagnostic, and also very good for therapeutic. We'll talk for a second about the diagnostic. So you can see rotator cuff disease as far as tears on ultrasound. You can see if there's bursitis in there fluid-wise. You can get a sense of if there's fluid inside the joint. You can get a sense of if there's damage to the biceps tendon. So and it's really nice because it's the cost of it's less expensive than an MRI. It's real time, as in it's like right there in the office, and you can get a really good sense. And also, there are people that can't get an MRI if they have pacemakers or things like that. And so it gives you an opportunity to evaluate them right then, quickly, inexpensively, and if they can't get particular tests. So ultrasound is really, really good for doing that. And of course, the learning curve is really steep for that. People need to be trained and things like that. And so, but it's a great way to look at patients as far as diagnostically. Now, therapeutically, it's like, it's huge.
Right.
So if you're injecting all those structures, you can see exactly where you're putting your needle in, exactly in the biceps, exactly in the biceps tendon sheath, exactly in the subscapularis, the AC joint, the subacromial space, all these things. And so you can precisely put that treatment there. And so for that, it's the only way to go. I always like to tell the story about there was some research done probably 7-8 years ago, and there was a paper that was done looking at orthopedic surgeons who injected the shoulder. And so, and they looked at them injecting it blindly and then looked at them using ultrasound. And so what they found was that when we did it blindly, probably only 40% of the time were we in the place that we thought we were.
Right.
And the rest of the time we weren't. And so, if you can go from 40% to like 99%, makes a huge difference.
Kind of a no-brainer. Yeah.
Yeah. If you're doing an injection, you need to have ultrasound. It's just, if you're doing it without it, you're doing yourself and the patient a disservice.
Yeah, absolutely. Now you said you utilize musculoskeletal ultrasound in office. Now here in Phoenix, it's a lot of times I'll get asked, or patients will ask, okay, well, do I go to an imaging center for this? And in Phoenix, I think there's maybe 20 people in the state that are trained in MSK ultrasound, and none of them work in an imaging center.
Right.
They're all in private practices. And so is that the same in Nashville, or is that something that's a little bit more open?
Yeah, no, ultrasound is something that's done in the office. You don't have to go to the imaging center for it, although imaging centers do have that. But it's super easy to do as long as you know what you're doing.
Okay.
And like I said, we do all ours in the office here.
Yeah, that's perfect. And Yeah, we do mine in my office, and like you said, the therapeutic benefit. I mean, it's nice to be able to use the ultrasound, see exactly what's going on, and then go and do the treatment, and know that your accuracy is 99% when you're doing that treatment. Yeah,
yeah. I mean, I was as a resident, I was trained to do these things blindly. We always thought like, gosh, we're definitely there, but
yeah,
you know, no, we weren't. And now that I deal with ultrasound, I wouldn't do it any other way. Like any injection that I do, I always do it with ultrasound.
Yeah, no, same here. So we talked about the three types of image, and the one thing that we didn't mention necessarily with ultrasound that I like a lot is that you can see the dynamic, like a dynamic movement, and see what's going on during that, right? So like if a patient's saying, "Oh, I have shoulder pain when I lift my head up, up to, or when I lift my arm up to 90 degrees," and you can put an ultrasound on where they're pointing to their pain and actually see what's going on in that moment, as opposed to like an MRI, X-ray. It's kind of a static image, and you can't see them move under it.
Right. Yeah, you get a good sense of, especially in that case with someone that may have impingement, right? So when you're raising that arm and that cuff is hitting the top of that bone, the acromion there, you can see that. You can see that ultrasound, and so you can see the fluid in there. You can see if that biceps tendon is moving when the arm moves, and so it's a great tool to use, and hopefully as time goes, everyone kind of gets this. It'll be the kind of the standard of care. Right now, I think people are like, oh, they're doing injections, and they'll say you don't need it. It's like, but you really do.
Yeah, absolutely. So we talked about the different types of images. Now let's talk about some of the stuff that we can find on the images that are causing shoulder pain, and then at the end of the day, we have PRP, we have stem cell therapy. What do you use to treat these things? So obviously one of the things, or I guess the two things I see the most in my office are going to be rotator cuff tendinopathy and joint instability. And so I'm sure that you have the same things, and I'm sure you have a little bit more because you're a surgeon, so you probably see stuff that's also surgical candidates. But why don't you tell us a little bit more about some of the stuff that you find?
Yeah, so the shoulder, which is probably my favorite joint. I love treating these, and
same here.
Ankles and all those things. But the shoulder is definitely my favorite joint because there's so many things that are in there. But the things that we want to think about when we're looking at a shoulder and evaluating it for pain and what's going on, and using the ultrasound to do that. So, number one, obviously, looking at biceps tendonitis and tendinopathy and rotator cuff. Those are going to be the biggest things that are going to be there. And as we think about those, a lot of people will ask the question, well, what's tendonitis versus tendinosis or tendinopathy, and it's definitely a range. And so sometimes like, well, is that inflammation? And sometimes it's not necessarily inflammation. Sometimes it just means that the tissue is damaged, right? So I like to think about it like a rope that you go to Walmart. It's a brand new rope and it's nice and tight and has no fraying to it. Mm-hmm. But as time goes, that rope, it's still strong, but it gets some fraying to the outside. It still works. And so that's how I kind of think about the tendinopathy or the tendinosis, and sometimes when you have that, you'll have pain with that. So you'll get that in the rotator cuff, you'll get that in the biceps tendon, and then one of the big things that you'll get is inside the labrum, you'll get kind of degenerative tearing. I bet if you and I got MRIs of our shoulder right now, we'd probably have some degenerative tearing. Now we may not have pain with that, but at some point in time, it can cause pain down the road potentially. And so as you're looking at those things, and then obviously trying to evaluate what you're going to do with it, those are the two big ones: the rotator cuff tendinopathy and biceps tendinopathy.
Yeah, for sure. And that's when you're treating those things, are you doing PRP, stem cell, both? Like what? I know a lot of studies show PRPs, proves that PRP has been effective for tendinopathy. Right. And so, what are you using in particular for your stuff?
Yeah, so it's very, very interesting, and my take on the regenerative medicine things is that PRP definitely helps and it can definitely work, and so you have that on one side, so you have the growth factors, and then you have the stem cells on the other. And in my book, stem cells are definitely king, right?
Yeah, sure.
But it just depends on how you want to treat it. Sometimes folks are like, well, I don't want to do stem cells. I want to do the PRP, the growth factors. And so that's definitely acceptable for partial tearing of a rotator cuff or biceps, things like that. And so we definitely can start there. Now, if I had my magic wand, I could treat everyone with stem cells. That's probably what I would do.
Right.
But definitely PRP has been effective, and I have several patients that we've treated with that, and can help significantly. And it depends on how big the partial tear is, and things like that, how much disease that's there, of how it works. If it's obviously smaller, PRP definitely can work, and sometimes you have to have kind of more than one injection to get there. But PRP definitely can work very well in partial rotator cuff tears, partial bicep tendon tears. That's definitely the one that you start with. But like I said, I think the one that's most powerful is doing stem cells with the addition of a growth factor like PRP.
Yeah, for sure. Now, you mentioned partial tears in the rotator cuff, biceps tendon, all those things. Now, is there a Is there a cutoff point that you have? So, like, if how big does the tear have to be, or all these things that'll either make you say, "Oh, this is surgical," or this can be treated with regenerative medicine?
So I'll tell you some of the things, and it is a work in progress in a continuum, right? So you have this very small tear to this very large tear, and you're trying to figure out what to do with it, right? And as a surgeon, I've definitely operated on people that they've done extremely well. I've operated on people and they haven't. I've seen folks that walk in the clinic, they have two massive rotator cuff tears, and they have great range of motion, they have great strength, but the only thing they complain about is pain.
Right.
And so you have to really, really evaluate the person,
Mm-hmm.
who they are and what they want to do, right? So there are times that I will say, yeah, we probably should fix that, versus, hey, we can give this a shot and see if we can get you out of pain. And so there's no cutoff number for me, so to speak. Someone would say, well, gosh, if it's retracted, you can't do anything with that with stem cells. But that's not necessarily true. And not to say that you're going to reattach it, right? We're not saying that. But if you can make that pain better in that very large rotator cuff, and they can do the things they want to do, then you've done your job, right?
Yeah, absolutely.
And so it really depends on the patient, what they're trying to do and where they are. Surgery is great, and can definitely help, but there's a continuum of small to large cuff tears that you can treat with. It depends on how aggressive the patient wants to be about not having surgery, right?
Right.
And so we definitely have folks that we've got, they've got some significant retraction, but as far as what they do on a day-to-day basis and how they can move their arm and their strength, they're doing really well.
Yeah, and I know, in my practice, as I'm doing these treatments, a lot of times it takes me a series of 2 to 3. Is that your experience as well? If you're doing, and I'm talking about PRP.
Yeah, definitely. Yeah, so definitely in my mind, I definitely like that series of 2 to 3, because one, just when I first started doing these things, I would find that with with one injection, I might get 60% of the way there.
Yeah.
And so it's like that 2 kind of get you over the hump, and 3 really kind of guarantees that we're gonna do well with it. And not to say there's a complete guarantee with it, but it really is in that 2 to 3 range with PRP.
Yeah, and I had a similar experience where, like, when I first started practicing regenerative medicine, I would go and treat someone. They'd get 60% better, sometimes even 100% with one, and then me still learning, and I was like, okay, well, yeah, you're good. And then, like, 3 months later, they come back for the same injury, and then it was when I started seeing that when I started doing the second and third one, it's like, okay, now I've seen them for other stuff, but the problem I initially treated with that that's been 3 years ago, so 4 years ago, so we don't have an issue anymore.
Correct.
Yeah. That 2 to 3 really does, like, help it quite a bit.
Yeah, it's very, very, and that's what I see in my practice as well. So, especially if we're dealing with just using growth factors or PRP.
Yeah, for sure. So we've we've discussed treating rotator cuff, biceps. You mentioned a little bit of labrum problems.
Right.
Go ahead.
Yeah, so I just, with labrum, everybody has a degenerative labrum, and that doesn't necessarily mean that there needs to be a surgical issue. But definitely the regenerative things, once again, can help with that. And when you consider the labrum, right, you're really considering the glenohumeral joint. So you're
right.
considering that. So normally there's a little loss of cartilage, so you've got arthritis in there, and so you want to kind of think about all those things. And so you're dealing with that degenerative labrum, but it's degenerative because there is pathology in there as far as the arthritis that's there, loss of cartilage and things, loss of joint space. And so you really want to deal with that. And so when you are thinking about those things, you address both of those too. So PRP is great, but once again, stem cells are probably keen with that as well.
For sure. And then I know one discussion that we've had that was kind of like I don't think it was on a podcast, on a previous podcast, but I know one discussion we had was using platelet lysate as well for treatment of nerves, right? And so like I have a patient who's a competitive swimmer, and we found that he had a supraclavicular nerve palsy that was kind of causing some issues with his infraspinatus and supraspinatus.
Yeah, suprascapular nerve. Yeah,
scapular nerve. Suprascapular nerve.
Yeah, suprascapular nerve. Yeah.
He treated that. He's responded super well to it. We talked about the joint, but then I also want to touch on the nerves for a second. I'm sure this is something that you do, that you've seen as well. Can you that a little bit more?
So going back to our SANS model, right? So the neuromuscular, like if you're like, oh, I'm just going to put this stuff in the joint and everything's fine, you're really not doing a complete job, and you really have to think about the nerves that are innervating these muscles and these joints, and so that one's huge, right? And so treating that nerve with platelet lysate to kind of open up the space around it, give it room to breathe so it can do what it's supposed to do. And instead of being pinched and not being able to innervate those muscles like it should, now it's not. And so now the muscles can work and help with stability and also alleviate pain. I mean, that's really huge and something that you really have to consider. If you don't think about that when you're looking at a shoulder, you'll totally like not help someone and you'll have done all this stuff without looking at the real pathology, and definitely platelet lysate helps really good around nerves like that. And another place that I love to use platelet lysate is in when you have bursitis, right? So you've got that subacromial space, and you've got that bursitis that's in there. That can really help with decreasing that swelling, and so I like to use that there. And kind of while we're talking about nerves, obviously you have to think about the neck when you're dealing with the shoulder, right?
Right.
If you are kind of a one-trick pony and you're like, oh, I just take care of shoulders, and you don't think about the nerves coming out of the neck, then you'll treat someone and it won't help them.
Right.
And so you really want to get all of that in there.
Yeah, get that piece looked at for sure.
Yeah.
Do you see a lot of AC joint instability in practice?
So, some with my competitive athletes.
That's the one that did it.
Yeah, I'll see that there. Usually in my older, my more senior saints, this is going to be arthritis that they are, or even my competitive athletes that are older, it'll be arthritis. But my younger guys, they'll get a little ding to their AC joint where they have a little shoulder separation, and in those situations, I like to use things like prolotherapy in addition to like PRP and things like that. I've got a kid he's playing D1 football coming up here in the fall, and had a grade 2. And so grade 2 in a guy that's an athlete, most folks would say, man, you got to operate on that.
Right.
But he was in the middle of the season and they wanted to continue to play. And so we treated him with those things. And he was out for about a week and a half, back to playing, finish the season. And, and he's doing great right now. No issues, no concerns. And so, and that, things like that is, those are the things that you live for. You love to see that and getting him back, and he's going on to do his thing, and hopefully will do well.
Yeah, for sure. It's cool to see, because I have a few high school athletes that have that AC instability. It's cool to see how quickly they bounce back from the treatments that I do on them compared to some of my 50, 60-year-olds that they eventually get there, but they take a few weeks longer.
Yeah.
Whereas you could do it on high school, college student, and in 2 weeks they're pretty good.
Yeah.
Yeah.
And also while we're talking about stability, one of the things that we have to remember with around the shoulder is treating the ligaments. So you've got the inferior glenohumeral ligament, you got the superior, you got the middle, and that inferior, you got the three bands that are there. And you can't underestimate treating those ligaments. Like, they are very important especially when you're thinking about that stability part of the SANS when you're looking at the shoulder, right? And I have this patient. She is 26 or 27, had started working out probably when she was 21, 22, and then subsequently just had this significant shoulder pain. I mean, like, it just would not go away. And she'd probably saw 2 or 3 orthopedic surgeons. And then so as she comes to see me, we're trying to look at her shoulder, as a whole, and taking this SANS and looking at it. And one of her biggest things was that she was having instability with her ligaments there.
Okay.
Treated those ligaments, it's like she's a new person.
Yeah.
And so, man, it's great to see. But, you have to look at it completely. We've got to look at the symmetry. We've got to look at the articulation. We've got to look at the neuromuscular. We've got to look at the stability. And when we put all those things together and then apply the things that we have, we can really get someone back to doing things that they love.
Yeah, absolutely. We'll close off with this, unless you have anything else to add. When you're looking at the outcomes for using regenerative medicine, what do you determine as successful? So, like, what's your definition of, okay, I was able to, that was a successful treatment for this patient?
Yeah. So the number one thing is if we can get them out of pain, right? So if their pain is gone, then that's a huge success. And then number two, if we can get them back to some certain activity, right? Sometimes it's modified, sometimes it's different, sometimes it's back to what they were doing. But that too is a measure of success. And so that's definitely our goal. And the great thing is if we can do that without having to do a surgical procedure or, taking anti-inflammatories all the time or doing steroid injections or those things, allowing the body to kind of heal itself, that's huge for us. And that's, why we do what we do. We want to get people active and moving and also out of pain.
Yeah, that's perfect. And I think that's a great way to look at a success is, not only, I feel like a lot of people focus on just the pain component. And, when we're kind of looking at, what we do and how we do it, it's, is the pain gone, but are they able to get back to, function and doing what they love? And that's, that's like the biggest part for me, for sure, is making sure that we're able to do that piece.
Yeah. And one of the things I want to add to that, and I think this is very important, especially as we talk about symmetry and stability. Yeah. There's a lot of things out there, and you deal with the shoulder. I'll never forget when I was in fellowship, and I did fellowship up in Boston at New England Baptist Hospital. And we have this sports symposium every year. It was a sports medicine fellowship that I did. And so one of the orthopedic surgeons there, he's a shoulder guy and very prominent here in the South. He came to Boston and spoke there. And of course, he spoke in this very Southern voice. Yeah. And so my fellowship mates were like, "Man, can you interpret what he's saying?" But and I just say that because as he went through his talk, he kept talking about core, mentioned it like, you got shoulder pain, and you look at the core. Shoulder pain, and you look at the core. Shoulder pain, and you look at the core. And he hammered this. And at that time, which was now probably 5, almost 6 years ago for me, I was like, man, core, like what in the world? Like we're talking about a shoulder here, and you're talking to me about core. I don't quite get it. Yeah. But as I and realized that he is a world leader because he talks about the core.
Yeah.
And so those things play into your shoulder pain, right? So if you're having pain in your shoulder, you got to look at the core. You got to look at the posterior chain. Are your muscles in the back firing? Are they doing what they're supposed to? Is that core where it's supposed to be? Are you breathing well? That's another thing that's kind of hot and new is you don't want to belly breathe. You want that diaphragm to work, right?
Right.
But when you do that, then your shoulder is going to be where it's supposed to be and do where it's supposed to be. And do what it's supposed to do. So there's a lot of things that go into that, and not just you can't. No longer do we just go, oh, this is I see some tendonitis here, or this is torn, and this is why you hurt. Like there's more to it than that these days.
Yeah, absolutely. And I think the best thing is that we're one of the ones that recognize that, and it's never ending. I mean, you're always going to keep learning and improving, right? Like
Right.
cool. It's cool. Yeah, I've heard that piece before too, with the core, obviously breathing, that diaphragm breathing and everything. Like
Right.
it's key for sure.
Yeah. Very important.
Cool. Do you have anything else to add?
I love the shoulder. It's so much fun. There's so many things in there, from the biceps to the subscapularis, supraspinatus, infraspinatus, the glenohumeral joint, the labrum. There's the nerves that go in there. It's a lot of fun. But when you evaluate it properly, you can hopefully treat some folks and get them better and get them out of pain and back to doing the things that they love to do.
Yeah, no, that's perfect. We'll go ahead and wrap it up with regenerative medicine on the shoulder. So, Ethan, thank you again for being on the show.
Yeah, no, Matt, thank you so much for having me.
We'll catch y'all on the next podcast. Thanks for listening.